Honorable ladies and gentlemen, may I have your attention, please? Our session is about to begin. Assalamualaikum warahmatullahi wabarakatuh. Welcome to the guest lecture session today with topic of cervical cancer prevention and colposcopy. I am Bagus Indra Cahya, your host for today. I would like to greet the head of Obstetric and Gynecology Department, Dr. Ardano Kusumanto, Specialist OBGYN, Subspecialist Oncologist, Dr. Muhammad Arizucha, Specialist Oncologist, PhD, as the moderator today. Honorable professors, fellow doctors, Professor Hare, the leader of the Indo-Cerca research team, and of course, our distinguished speaker from Hanover Medical School, Professor Dr. Peter Hillemans. Welcome to the Department of Obstetrics and Gynecology, Gadjah Mada University. As I stated before, the main topic of today's lecture is cervical cancer prevention and colposcopy. For around next 1 hour, we will learn a new insight and lesson from current approach of preventing cervical cancer. Professors, doctors, distinguished ladies and gentlemen, please allow me first to read the agenda for today. The first agenda is the opening session, welcoming speech from the head of Obgyn department, guest lecture session, discussion, and closing. To open this lecture,
where the screening coverage is still low, quite low. So its results, the patient will come to us often in advanced condition. I would like to thank to Professor Hillemans, the chairman of the Department of OBGYN, Hanover Medical School, who this morning will share knowledge about cervical cancer prevention and colposcopy, as well as to my colleague, Dr. Muhammad Arizucha, PhD, OBGYN, who will act as moderator this morning. I also thank to the participants. I hope this event can add our insight in preventing cervical cancer. I would also like to thank to the organizers for making this excellent event possible. Let us always compete in goodness. Wassalamualaikum warahmatullahi wabarakatuh.
thank you for Dr. Adriano for the welcoming speech. We are now continuing our session to the main agenda. That is to hear the keynote speech that will be delivered by Professor Dr. Peter Hillemans from Hanover Medical School. The lecture itself will be moderated by Dr. Muhammad Arizucha, Specialist OBGYN PhD. Before we proceed to the session, I would like to read Dr. Zucha's curriculum vitae. Dr. Muhammad Arizucha, Specialist OBGYN PhD, was born in February 10th, 1987. Dr. Zucha graduated from Gadjah Mada Medical School at 2010. After that, finished PhD program at Taipei Medical School in 2015. Later on, finished the OBGYN specialist in Gadjah Mada in 2021. Dr. Zucha was also known for the several international papers published. Some of them are in Asia Pacific Congress of Gynecologic Surgery, Indonesian Congress of Obstetrics and Gynecology, and etc. So, ladies and gentlemen, please welcome Dr. Muhammad Arizucha, Specialist OBGYN PhD, as our moderator today. Please give applause for Dr. Zucha.
Oke, Assalamualaikum warahmatullahi wabarakatuh. Good morning. My gratitude to all professors and, of course, our respected guests, Professor Hilmans and Professor Haya, our dear colleagues and resident doctors, young doctors, who are very delightful today. I think that we have a very interesting guest lecture topic in precancerous lesion prevention and also the colposcopy. As Dr. Ardhanu mentioned before, that Indonesia is still facing a big problem here, very low screening rate and high incidence of cervical cancer. So we do hope that we will learn something very new insights and the current updates in cervical cancer prevention and colposcopy from the expert, Professor Hilmans. First of all, I would like to introduce our distinguished lecturer today, Professor Hilmans. Would you please provide his, okay. Professor Hilmans is currently a professor in Hanover, and he is a very tremendous expert with various experience. And now he is the director of a comprehensive cancer center in Hanover, one of a very excellent cancer center in Germany. And he was also the past president of Northern German Gynecologic Society. He was also one of the committee member of the prevention of cervical and other cancers guidelines in Germany. So I think he is the very expert in these fields. So please welcome Professor Hilmans to give us lecture. Please welcome.
Thank you very much for this very nice introduction. Yeah, dear colleagues, dear professors, dear doctors, dear young doctors, dear big auditorium, it's a privilege to be invited here to your place. It's a privilege for me to come to Indonesia. The first time that I came to Indonesia, it's now 40 years ago, it was 1983. As a medical student, I traveled a long distance through Java to Bali. I spent about 6 to 8 weeks in Indonesia at that time. So coming back after 40 years is really a great, great pleasure. Well, let's start with the talk. Can you just open my slides, please? With the next coming half an hour, 3/4 of an hour, these are the topics I want to present. It's cervical cancer screening. It's first we start with some slides about HPV virology and cancerogenesis. Then we talk about the triage methods, which are very interesting and very important for cervical cancer screening. We come to the next slide. Here you see the WHO director. Sorry, just one slide back. Oh. Next one. Shall I use here the pointer or? Yeah. So the WHO Director General called to an end of cervical cancer. I think this is very important. The elimination of cervical cancer as a public health problem. The worldwide reduction of cervical cancer incidence has been proposed, and it's been said that the goal is to introduce vaccination worldwide so that every young girl and young boys between the age of 9 and 13 years of age can get the vaccination. Then 70% of the women screened should have a high precision test once they're at the age of 35 and at 45. And then finally, 90% of women identified for cervical disease should receive treatment and care. So this is a big and huge challenge to get it introduced worldwide up to the year 2030. Now, I want to present you some data in the Western world. You see here the incidence of cervical cancer, which decreased in countries with a prevention program. It's a little bit difficult to see and to read, but you see that on the left side, the countries in the Western world started with cervical cancer prevention by cytology, by pap smear screening in the year 1970. And you see over the next 20, 30 years, a significant decrease in the cervical cancer incidence in those countries who introduced the cervical cancer screening. And we achieved in Germany a reduction in the cervical cancer incidence by about 75% within a period of 3 decades. So this is a case of radical hysterectomy in a woman of 36 years of age who got a radical hysterectomy because of the diagnosis of cervical cancer. However, cervical prevention failed in this case. Cytology said that there's only a benign lesion without any hints for cervical cancer. The patient presented, however, with a positive human papillomavirus test. And due to the fact that the human papilloma test was positive, the patient got further examined by colposcopy and then diagnosed by cervical cancer. So we see the challenges of cervical cancer screening by cytology. Cytology is not as sensitive as HPV testing. And in the further slides, I will explain why. First of all, we are challenged in gynecology with the 2 main cancer, endometrial cancer and cervical cancer. Endometrial cancer you see here on the left side, cervical cancer you see here on the right side, with a focus on cervical cancer. Cervical cancer, next slide please, just wait a second. Yeah. Cervical cancer lifetime risk is quite high in various countries. I presented you data from the so-called IRC handbook, which was issued in 2022. You can get an online approach to this IRC handbook very easily. You see in Asia, the countries listed above, the Maldives and Indonesia, they're quite high for the cervical cancer incidence. And on the right side, data from Europe are being presented, where in Eastern Europe, the incidence for cervical cancer is also high. These are countries where no cervical cancer screening has been introduced on a large scale. So in Asia, the lifetime risk is highest in Maldives, in Indonesia and Mongolia, and lowest in Iraq. And it's quite high in Eastern European countries still now. Here you see data from Indonesia, where a pilot study has been run in the year 2007. And the screening has focused mainly on so-called VIA, visual inspection with the help of acetic acid. The target range is 30 to 50 years. And you see that the participation rate here has been, according to the publication, rather low, with an uptake of less than 8% of the female target population between the age of 30 and 50 years. So VIA is an accepted approach, but the problem is it's not being taken up by the women. It has not been effectively introduced to the whole female population. An alternative would be cytology, as it mentioned here as well. Cytology every 3 to 5 years would be an alternative approach, being recommended also in Indonesia. Let's switch to the next one. Oops. Well, medical scanner. In the old days, years and decades ago, we watched the Star Trek, and Mr. Bones, Dr. Leonard McCoy, was the chief medical officer of USS Enterprise. Yes, we talk about the year of 2266. And he used a medical tricorder with a handheld scanner. And with that scanner, he just approached the skin on the forearm. And by that, he could detect diseases. It would be just great to diagnose cancer by such a very simple approach. But we are not at the year 2266. We are just in the year 2023. So what is the situation of today? Well, right now, there's a huge American Society Clinical Oncology Congress taking place, the so-called ASCO. And one of the important information was also that there is a blood test for cell-free DNA, which is a multi-cancer early detection test. So you just take a drip of blood. By that drip of blood, you may be able to diagnose up to 50 various cancers. So that's a huge step forward. However, the test should be used in addition to guideline recommended cancer screenings. For cervical cancer, we want to diagnose not the cancer by itself, but we would like to diagnose the precancer. So that test would be of no help to diagnose precancer. It's only effective if cancer is there. But it's very interesting. This blood test for cell-free DNA relies on the methylation patterns of shedded DNA into our bloodstream. So methylation is an epigenetic modification of the DNA seen within tumors. This methylation can also be used for cervical cancer screening, but not from the blood, but from the cells of the cervix. Etiology. You know that human papillomavirus is present in cervical cancer. By very distinguished biochemical, virologic methods, it has been able to show that more than 90% of cervical cancer cases contain HPV, DNA, RNA, parts of this in a certain form. It's a double-stranded DNA virus. The lifetime risk for each person is quite high, between 50 and 80%. And then virologist in Germany has mentioned that it's like a viral cuff of the cervix to get human papillomavirus. Yes. So it's very common. It's just like herpes. And this question is only, can you get rid of the virus? Can you eliminate it? Is the immune system strong enough to all right. Yeah. So the very important point is that with the etiology that human papillomavirus infection has a spontaneous remission rate of 90 to 95%. Yes. So there's only a few women and few men who really have a persistent human papillomavirus infection. And this is the most important form, the persistency of this virus infection. And this may cause problems. This may cause then precancer, and this finally may lead to invasive cancer. So let's jump to the next slide. Yep. Or you can more or less push then the button forward is. So here is the phylogenetic tree of the undergenital HPV types. You see we have meanwhile up to 200 various types of human papillomavirus. However, we do concentrate on the genital HPV types, and you see in the upper part the high-risk HPV types. And actually, we do concentrate here mainly on the high-risk HPV types with HPV 16 and 18 and the other high-risk types which are relevant for cervical cancer prevention. Now, let's jump to the next slide. Yeah. In the low-grade cervical dysplastic diseases, we see no predominance of certain HPV types. You see that the HPV types like 16, 18, 16, 11, in the 30s and 40s, they are more or less equally distributed. However, in the high-grade CINs and cervical cancer, you see the dominance of HPV 16 and 18. So the two types, HPV 16 and 18, are the HPV types who are the most oncogenic ones, and which may lead to quite an early onset of cervical cancer. And this is also important because we could also stratify the risk for invasive cervical cancer depending on the HPV type. Let's jump one forward. So HPV infection, cervical cancer. It takes years before the HPV infection will finally lead to invasive cervical cancer. The initial infection with HPV takes place, and it takes 1 to up to 5 years for the emergence, for the occurrence then of a high-grade CIN of CIN2 and 3, and 10 years and more before the initial HPV infection will lead to cervical cancer. So you see that we have about 10 years, up to 15 years, more or less, to find those women, and partly then men, who will in danger of becoming an invasive disease. Where takes the infection place? The infection and the development of cervical precancer takes place at the so-called transformation zone. The transformation zone is the zone between squamous epithelium, which is the yellow line, and going into the endocervical canal of the cervix, and at the border of the glandular epithelium and squamous epithelium, at that transformation zone, at that squamous zone, the infection takes place and the development of precancer and invasive cancer. But it's not at the cervix only, which you see here on the right side. It can and may happen also here in the anal area. Anal cancer has a strong link to human papillomavirus. And even in the oropharyngeal area, there are also the squamous junctions where the infection and then finally the oncogenesis may 5%. You see that the possibility of the invention of vaccination has a great effect not only on cervical cancer incidence, but if we distribute human papillomavirus vaccination, preventive vaccination, we may prevent all these cancers. So one huge step forward by the WHO is the recommendation of human papillomavirus vaccination. Here is shown by the human HPV vaccination. It contains 7 high-risk HPV types in Gardasil 9. And you see that with the HPV vaccination, we can prevent up to 90% of cervical cancer cases. So this is a huge step forward for the prevention of cervical cancer. Not only cervical cancer can be prevented, but 85% of SIN2 and SIN3 and 60% of the SIN1 cases. If you do, and if you perform the vaccination in boys and girls between 9 and 14 years. Now, let's jump over. Is there a role for therapeutic vaccination for cervical pre-cancer? Very interesting. There are a couple of studies being published right now. And so we just published a paper last year in the Clinical Cancer Research. And we had a very nice therapeutic vaccination program ongoing. And I can show you the data in a second. We could manage that by vaccinating women with CIN2 and 3. We saw a reduction in the lesion size. However, we could not manage. This is quite complicated DNA plasmid vaccine, which has been introduced in the muscle. It's a vaccine technology, quite similar the COVID-19 vaccine technology. Just shortly to be summarized, actually, we could reduce lesion size. We could show that their effect is quite significant, with about up to 50% of the lesion being regressed. However, we could not achieve a high, let's say, remission rate up to 90% compared to colonization or any other technologies. Oh. Now let's go to the next one. So coming to cancer screening. What is the aim of cancer screening? Cancer screening is always a good balance of the risk. What does it mean? On the one side, we want to have a test which is very sensitive, which should not miss cervical cancer. However, on the other side, we should have a test which does not cause too many unnecessary interventions, which may be not too expensive and not time consuming. So this is the challenge of today, still of today, all over the world. We would love to have one test, I showed you already, a very simple test where we know exactly, okay, this is a CIN3, a precancer, who may progress to invasive cancer. At that stage, the test should become positive. Should not become positive at the first stage of low-grade dysplasia, because so many will have an HPV infection. We do not care about infection. We care only about the precancer situation. And this is the challenge. PAP testing has been introduced 30 years ago. However, by PAP testing and even by HPV testing, it's not enough. You need a secondary test like colposcopy to see whether there is really a lesion going on. Then colposcopy is always linked to taking biopsies. Only if you have the biopsies showing that there's a SIN3, then you should do a treatment. So you see, only one step is not enough. It requires several steps. And this is always a challenge for all countries worldwide, and especially for your country as well, because you have thousands, 10,000, millions of women to be screened. So cytology has been in place, but cytology is very, very cumbersome. And it needs a lot of women, a lot of cytotechnicians to deal with that. So this has been challenged all over the world, and still in Germany, we are going to switch from cytology screening right now to HPV testing, because HPV testing is much more precise. This is an example of liquid-based cytology showing high-grade squamous intraepithelial lesions, which corresponds to SIN3. Let's jump further on. This is a case of cervical cancer by cytology, but it's not always as nicely presented and to be seen with the pap smears as shown here. Let's move on to the next slide. So this is one of the pivotal studies showing that screening with HPV is better than cytology. Is a 1 million women at the age of 30 and 64 years, which have been screened by cytology and by HPV testing. And you see that the risk for SIN3, if you're undergoing cytology screening, can be pushed down if you add HPV testing. HPV testing may prevent cervical cancer. This is here a meta-analysis showing that the reduction of cervical cancer in the HPV arm by HPV can reduce by 70%. These are data from a pilot study in Germany, and there was the introduction of HPV testing in the northern part of Germany as a pilot study 15 years ago, and they had 3 rounds. Every round was 5 years, and you could see that after the second and after the third round, CIN and CIN3 went down from that incidence to that incidence. And even the cervical cancer cases dropped down significantly. So with the introduction of HPV testing in the area around Wolfsburg, northern Germany, Lower Saxony, we could show that HPV screening is a huge step forward. So what is the options, the other options besides colposcopy, besides HPV testing? This is colposcopy, and also we talk about VIA, visual inspection with the help of acetic acid. So what are the data of to now? How effective is VIA in lower and middle income countries as a screening method? I would like to refer to the meta-analysis being presented at the ARC handbook I mentioned earlier, being published in 2022, and you can go to the internet and read all the data. So visual diagnostics, VIA, has certain problems. I do not want to go into details. You can read it here on my slide. Let's go to the meta-analysis and see what data are there present. In the handbook, there are 2 bigger studies, major studies, which have been run. One is in South Africa, and the other one has been run in India over a longer period of time as a randomized controlled trials. So, what is the final conclusion of these 2 major studies? The conclusion is that HPV screening shows better results compared to VIA. If you introduce HPV screening, you see that you have fewer cervical cancer cases after 1 or 2 rounds, and you have fewer advanced cervical cancer cases. So these data are quite impressive. However, the question remains, how can this be introduced into the field? Very interesting also this study. Once you have positive HPV cases, what should you do? How can you more or less precisely define what kind of lesion is behind the HPV positive ones? What kind of test should you use? Can you use VIA for those women who are HPV positive? And how good is VIA to detect then the lesion, the SIN3, in those patients with HPV positivity? This study and this meta-analysis has addressed this question. And to summarize, if you have a VIA for the HPV positive cases, you may detect 70% of the sensory lesions. That means if you have 100 women being HPV positive, high-risk HPV positive, and you follow them with the VIA, you may not detect everyone. However, 70% of them. So you may miss 30%. Yes, we will not get always all, let's say, women on all pre-cancer cases. We miss them. This is actually linked to every test form and every triage form. So triage after HPV screening with VIA has a 70% sensitivity. It's less good than colposcopy, but seems to be acceptable. Yeah. However, you see it in Indonesia. The implementation of VAA is a challenge. It's really a challenge. Yeah. You have to do it for how many millions of women here in this country? You have to establish a good healthcare centers. You have to establish good healthcare workers. So the workup is quite challenging. For the National Cancer Plan in Germany, it took us 10 years to shift from cytology to HPV testing. It was a major challenge because it was not only HPV testing, because we had to introduce colposcopy clinics. And we had to level up our colposcopy clinics up to about 300 colposcopy clinics for Germany. And we have 85 million people in Germany. And it costs us millions of money. Our cervical cancer screening program costs up to €1 billion per year. Yeah, and so it's not easy to recommend this to other countries. So the introduction of HPV-based screening in Germany took place 2020, and it was a very humble way. A lot of resistance by gynecologists who said, we do not want to leave cytology. We would like to stick to cytology. I was responsible for the cervical cancer prevention guideline. I was accused that I will more or less destroy cytology, because cytology is such an effective method. And the problem was that our gynecologic doctors were accustomed to cytology for the last decades. They know how to use and to handle cytology, and HPV testing was very new. And also, the intervals. If you take such a sensitive test like HPV testing, you do not need to screen every year or 2 years. You may screen every 5 years. Then you lose patients, yes? And then you lose money. Making no money is no good, yes? That's why I had so much resistance in Germany for introducing HPV testing. They were blaming me that I just pushed a test and I'm being paid by the company, which was not true. So coming back to what can be done in your area, in your scenery. So certainly screening and triage, it's a big challenge. So having a good screening test like HPV will not help you anything. Yes. The question is, how do you find those women who do not only have high-risk HPV testing, but who have a lesion and disease? And this is a challenge. And there are certain ways you can more or less use some markers. After your HPV testing, you can use markers like methylation markers, genotyping, and also some sort of immunocytochemistry. So special techniques. And a lot of studies have been done over the last good 10 years to see the value of those triage testings. I've listed up the various possibilities for triaging the HPV positivities. So you could follow up HPV positive women by cytology and colposcopy. You can do again high-risk HPV testing. You can use methylation markers. Let's now concentrate what we have done in Germany. This is the German cervical cancer screening program being established 2020. You see, it's still complicated. We still stick to cytology for the young women. Yeah, between, that's not correct, 25. We start with 20 years. Between 20 years and 34 years, we're still in Germany are taking every year a pap smear. Although we know that cervical cancer below 30 years of age is very low. Someone is below 30 years of age, hardly you need any screening. You may start with 30 years of age. The WHO recommended screening at 35 years of age and 45 years. If you do a one time per life screening with HPV testing, you should do it with 35 years of age, and then you have the most of the benefits. But then the question is what to do. We started with 35 years and beyond with the co-testing every 3 years. And it was not easy to implement, as I mentioned already. So coming to the next conclusion, this sort of prevention program is very expensive. It requires a lot of controls. And below 30 years of age, there's only few cancer. You spend a lot of money, a lot of problems with the interaction of women, calling to the doctors, calling to the midwives, whatever, doing the screening without any, let's say, positive effects. Yes. So what would be an alternative? Still, you need for primary screening a very sensitive test such as HPV testing. It's not necessary that you take a direct sample. We know from good studies that not the midwife or the doctor is necessary to take the sample directly from the cervix. You can take it although as a vaginal self-sample. You can ask the women, take the sample from the vagina, and the sensitivity for the PCR of HPV is more or less as sensitive as if me personally, as a professor, taking the pap smear or the smear directly from the cervix. Another alternative is to take urine. First of all, urine. Very nice and interesting data over the last 3 years have been accumulated to show that first of all, urine with a special selection method. So you have to really take the first of all urine. Otherwise, the dilution with urine is too high. Is very quite acceptable sensitive. And so this has been evaluated then also by the Intercircle study. So this would be a primary screening challenge. However, what do? You start with the HPV testing with 35 years of age. You could triage then with VIA. Yes? And then you go with a kind of a see and treat. Say, okay, the VIA which are positive by acetic acid, I do the treatment. This would be quite straightforward approach. You do it with 35 years of age, and then you do the next test with 45 years of age. And again, you do the HPV testing, do a VIA, and the VIA positive one, you go for see and treat. If you have the possibilities, the money, the structure, the infrastructure of colposcopy clinics region-wide, then you could also use colposcopy with taking biopsies. But then for taking biopsies, you have to take biopsies. You need the histology, which also is costly and requires a lot of resources. So it's less expensive, more practical. If possible, use colposcopy instead of VIA. However, it requires doctors who are then in charge of taking histology. So these are the challenges. What is with methylation? We mentioned methylation, the blood test methylation, but there's also a methylation for clarification of HPV positivity. The genetic and epigenetic changes in the host genomes are components of the oncogenic process. Yes, and methylation correlates with the severity of CIN. High methylation levels of the tumor suppressor genes are found in SIM3 and several genetic aberrations. So methylation is a way forward. And for methylation, actually detection, you just take the same sample you have used for HPV testing. You take the same sample you used it for HPV testing. If it's HPV positive, then you make the methylation testing as a second step out of one vial, out of one, let's say, one smear being taken. So a program could be that you start with a screening with HPV, and then if HPV is positive, then within the same sample, you run the test, you triage this with the methylation test. So let's assume that the woman cohort is being tested with HPV. Let's assume you have then a positivity rate of about 5%. 5% of the women are then HPV positive. Depends on the area, depends on age. Those who are HPV positive, you do out of the same vial, as a reflex testing, the methylation test. And this will cut it down probably by 2/3 or even more. And only those lesions are then left. And those lesions have then a high probability that there is cervical cancer or precancer. Just taking one smear, doing the test, 2 tests, it just out of 1 vial. So this is without any VIA, without any colposcopy. However, you always have to bear in mind that with such an approach, you will have a certain number of women who may have no disease, who are just HPV positive and are a little bit methylation positive as well. Yes, but it's always the balance, as I mentioned before, between having the possibilities of colposcopy, of taking biopsies. The possibilities is not there. Then some of the women having no disease have to be treated as well. Treated, the question is how? Either by cone, by loop electrosurgical excision procedure, by cryotherapy or whatever. So, and this could be done with 35 years and 45 years. So it's a pure, let's say, biochemical, virological testing, depending on one time smear. So less expensive, more practical. It involves no VIA and no colposcopy. Yeah, so this could be also an alternative. All these kind of, let's say, theoretical approaches are being evaluated right now in studies and could be also evaluated here in this scenery, then in pilot studies as well. For colposcopy, colposcopy is a highly valuable and very exact way of diagnosing the disease. But establishing colposcopy clinics all over Indonesia is a challenge. I can tell you from Germany, it was a challenge in Germany as well. We could only establish it in Germany because we told the gynecologists they get money for it, good money for that. Then they said, okay, I will learn colposcopy. Yeah. And, but we had the infrastructure already. We have in Germany, we have about 20,000 gynecologists in Germany. 20,000, yes. So they're all over the places. So the program relies on doctors then to have the ability to have colposcopy. So I'm not sure whether it can be spread out in Indonesia within the coming years, so that you may rely on the colposcopy evaluation of patients or of women having higher risk for developing disease. So, and final conclusion, colposcopy is a good way of exactly diagnosing disease. However, it takes resources, lots of good resources. Alternatives such as fluorescence diagnosis for CIN, just to make it easier, are not really in place. We did a lot of studies in the last decades to establish an alternative for acetic acid staining. However, for the routine, it's not really recommendable. Yeah. So finally, by colposcopy, you need then also taking the biopsy, and the biopsy cannot be taken, I guess, by midwives. In the US, actually trained nurses run colposcopy clinics and taking biopsies. Yes. In Germany, doctors taking biopsies by colposcopy. I don't know in Indonesia whether it would be possible to have the colposcopy and taking biopsies being done by midwives or by trained expert healthcare workers. Yes. It has to be debated who may do this procedure. If it's not possible, then colposcopy probably is not the right way to go. Then you have to go for VIA or even think about a way avoiding these very cumbersome VIA and colposcopy technologies and then rely only on, let's say, on techniques such as HPV testing, methylation assays, etc. So this is in summary the overview I would I'd like to present you. There are certain things I would like to mention. Finally, this is the organization and invitation program. It's a quality program. Without any quality assurance programs, these screening programs actually do not work. But this takes resources as well and a good infrastructure as well. By that, I would like to finish my talk. I think the time is over. And I thank you very much for the attendance, and I'm open for the discussion.